بسم الله الرحمن الرحيم. Dear Chairman, dear colleagues, يسعدني ويشرفني ان انا اكون موجود في وسط اساتذتي وزملائي من جامعه جنوب الوادي ومن كل جامعات مصر، وطبعا جزيل الشكر لاساتذتنا استاذ دكتور سيد بيه واستاذ دكتور تمام بيه على دعوتهم الكريمه. هو بس في غلطه بسيطه، هي طبعا انا مكتوب كايرو يونيفرستي، هو انا بنها يونيفرستي في الاثنين. طبعا انا يشرفني ويشرف اي حد ان هو يكون في كايرو يونيفرستي، بس ده فور بوليتيكال ريزونز، انا دين اوف بنها يونيفرستي فما ينفعش اتكتب في جامعه ثانيه. فيعني احنا قبل ما نبدا التوك انا طبعا بدعو حضراتكم جميعا ان انا كان ليا الشرف العظيم ان انا اكون مسؤول على الارثروبلاستي سيمبوزيوم او الارثروبلاستي سيشن في المؤتمر القادم لجمعيه جراحه العظام المصريه. ان شورت، هو احنا الحمد لله بفضل الله وتوفيقه وبرعايه البورد المحترم ورئيس جمعيه جراحه العظام المصريه المحترمين، انا من فضل الله سبحانه وتعالى كان ليا شرف ان انا دعيت 4 من كبار اساتذه العظام في انجلترا والارثروبلاستي. نمبر 1 بروفيسور سيب ستورج فروم فريملي بارك هوسبيتال. نمبر 2 طبعا العملاق بتاع الارثروبلاستي في جامعه ليدز بروفيسور بيتر جيانودس، طبعا ده اكبر واحد سايتد في العالم وده الاديتور بتاع انجري جورنال. نمبر 3 بروفيسور زهير نواز بروفيسور اوف اورثوبيديك اند ارثروبلاستي سيرجن فريملي بارك هوسبيتال. and number 4 بروفيسور دوغلاس دانلو from Southampton University. والخبر الجميل اللي عايز اقول لحضراتكم، امبارح لسه مأكد عليه بروفيسور سيب ستيرتش، وهيبقى ليه في الاوبننج سيرموني هيبقى ليه توك هو وبروفيسور موريشيو رافاييلي من البرازيل. الاثنين الحمد لله من فضل الله انا اتفقت معاهم برعايه اساتذتنا في البورد ان هم الاثنين جايبين فيلوشيب بروجرام للدكاتره المصريين. فالحمد لله رب العالمين بروفيسور سيب ستورج الفيلوشيب عندهم معموله للدكاتره اليونانيين، والحمد لله وافق ان الدكاتره المصريين يدخلوا فيها. اتس فيلوشيب فور 2 years. الريكوايرمنت الوحيد ان اللي هيروح يبقى معاه بلاب او يكون معاه ريجستر في الجي ام سي، ودي فيلوشيب فور 2 years للشباب المصريين. الحاجه الثانيه موريشيو رافاييلي ونايون انستيتيوت، ده اكبر انستيتيوت اوف شولدر سيرجري في البرازيل، وده برضو معاه فيلوشيب بروجرام for 3 months للشباب المصريين. فان شاء الله ربنا سبحانه وتعالى تكون فتحه خير على يعني اولادنا وزملائنا من الشباب المصريين ان شاء الله. My talk will be about the acetabular deficiency, the nightmare. The causes of bone loss. The causes of bone loss, deficiency and acetabular bone deficiency. Deficiency of the acetabular bone stock is one of the major problems in revision total hip and certainly in certain primary total hip arthroplasty. It may result from numerous factors numerous causes such as osteolysis caused by wear, loosening, infection, excessive bone resection at the time of previous surgery, and pre-existing bone deficiency from acetabular fracture, and lastly, inadvertent distraction during removal of the acetabular prosthesis in revision surgery. During preparing of an acetabular revision surgery, management is focused mainly on 5 main items. Number 1, can stable fixation be obtained in the remaining host bone with or without immortalized bone graft? Number 2, are there segmental defects that necessitate structural arrow graft with a high hip center, or I can go to the second option, which is the high hip center. Number 3, is bone loss is so severe that stable cup support and fixation cannot be achieved just only by grafting. Number 4, is there a pelvic discontinuity? And this is a very important subject that requires fixation. And number 5, what's the optimal surgical exposure to facilitate the acetabular revision? Classification of acetabular bone loss and acetabular deficiencies. احنا عندنا many classifications for acetabular deficiencies. 2 of them are very famous. The AAOS classification. The AAOS classification is mainly focused on either this deficiency is segmental deficiency or cavitary deficiency. Segmental deficiency either may be a rim deficiency or a central deficiency, the medial wall deficiency. The cavitary deficiency, combined deficiencies, and is there a pelvic discontinuity. And the second most famous classification is the Paprosky classification. The Paprosky classification is mainly focused on there is a type 1 minimal bone loss, type 2 column intact and supportive, and type 3 column non-supportive. Goals and principles of acetabular reconstruction. Acetabular revision should aim to, number one, achieve a stable fixation. Number two, restore the anatomic center of rotation of the hip. Number three, provide a well-contained component in correct orientation. And we go to the next slide, management options. In many of the acetabular, the greatest volume of intact viable host bone is cranial to the normal hip. بالتالي أنا عندي two main options of management. The first option, reaming into the best available host bone and place the component in a cranial part, which is called the high hip center. The second option is to reconstruct, attempt to restore the center of rotation by reconstructing the acetabular ring. First option is the high hip center. To optimize host bone implant contact, I have to make the contact in a higher level. It has advantage and disadvantage. The main advantage is the shortening of the anesthetic and surgical time and reducing requirements for bone grafting. And the disadvantage is the aseptic loosening. The dislocation are more common and leg length discrepancy. The reconstruction option. I have many reconstruction options for the acetabulum. Number one, the bone graft. Number two, extra large uncemented hemispherical acetabular cup components, which is like the jumbo cup. Acetabular reinforcement rings. The ilioischial cages. The implants for pelvic discontinuity, such as the custom triphalange implants and the cup cage construct. And lastly, we will speak about the trabecular metal augments and trabecular metal components. The trabecular metal components, trabecular metal constructs are designed to maximize the degree of biological fixation. The trabecular metal components have the following advantage. In brief, عشان ما ناخدش وقت, in brief هم لهم osteoinductive and osteoconductive property, simulating the bone grafting. The trabecular metal augments, ودي أهم حاجة. The shape of the trabecular metal augments, and every shape is designed to restore and reconstruct a defect in a special place. Number one, the trabecular metal wedge augments. Number two, the trabecular metal patris augments, and these address extensive superior segmental defects. Number three, the trabecular metal retractors, and it's used to rebuild the medial wall. And number four, trabecular metal shim augments placed between the patris augment phalange and the host bone to optimize the fit of the patris against the iliac bone. Intraoperative possibilities, ودي يعني هنعديها بسرعة. ازاي ان انا بحط الtrabecular metal augments to reconstruct the defect. I have two main cases to present based on what we have said. Case number one, it's a female patient, 65-year-old, with total hip arthroplasty. The total hip was done 13 years ago. The patient presented with a septic loosening of the acetabular component, no past medical history. The C-reactive protein was, كل infection profile كانت negative. C-reactive protein, ESR was 15 for the first hour and 25 for the second hour, and the total leukocytic count was normal. This is the pre-operative imaging, the X-ray showing septic loosening. You can see the loosening. Pointer مش شغال, sorry. You can see the loosening of the acetabular cup, and there is a acetabular deficiency in the superior part and the more or less in the anterosuperior part. This is the CT scan. Intraoperative stem, the stem was stable. The loosening was mainly in the cup. The stem was stable, and revision was done for the acetabular component. This is the immediate post-operative X-ray showing the trabecular metal augments fixed with screws. 4 months follow-up X-rays, the cup is still stable. After 14 months follow-up, it shows stable acetabular component with excellent both clinical and radiological results for this patient. Case number 2, we have a male patient, 59-year-old, with bilateral total hip replacement, was done 20 years ago, presented with aseptic loosening of the left prosthesis and left hip pain, no past medical history, all the infection profile was normal. Intraoperative, the femoral component was stable, very stable, and the acetabular defect was reconstructed with trabecular metal wedge. This is the preoperative imaging showing loosening of the acetabular component and acetabular deficiency. This is the immediate postoperative showing the trabecular metal augments well fixed. And this is after 1 month follow-up with excellent clinical and radiological follow-up. And this indicates that the trabecular metal augment is an excellent option for managing the nightmare of acetabular bone deficiency. Thank you so much.